This one's going to be very interesting, though. I'd like to ask my panelists to come up. We're going to have a discussion, but I first wanted to ask everybody here, because we work in acronym soup when we get into government talk, how many of you know what an LHD stands for? Oh, winning, good. And the reason I wanted to ask the question is because that's the integral part that this program is really about, is making sure that you are supported by your local health department. One of the reasons this is so important is about 6 years ago, the Department of Public Health had a very similar program working with the California Medical Association, inviting, training, preparing doctors. Part of the challenge with that was you were set free to work on these different issues and to try and to be well-versed, understand the issues, know how to address some of these things, but there wasn't the component of having the local health department as your partner in all of this. And that's what we wanted to talk about today. That's what my panelists will be giving us some perspective on. These truly, we need to understand that these really are your partners. That there was an earlier conversation yesterday about, there's only so much I can do. I'm a physician, I'm working 40, 60 hours a week. How will I have the time to really involve this? What we want to do is make sure that we've created a real partnership with your local health departments, that they're being able to advise you, to counsel you, to support you, to find opportunities for you, but that you also know some of what they're trying to do and how they're trying to do it. And it's a real pleasure today to introduce my panelists. These are, we had the opportunity to work with, I've had the opportunity to work with all three of these folks all over the state. They're doing some amazing progressive work on nutrition, but also really integrating policy, system, and environmental work so that there's a sustainability to the work that they're doing. So they truly are changing their communities, and I think in all three of these communities we'll be able to talk a little bit about that. Now the glasses have to go on. This is the introduction time, Steve.
I feel you.
So, first of all, I wanted to introduce Steve Baldwin, who is the Director of the Los Angeles Department of Public, Director, it says right there, Director of Los Angeles Department of Public Health, Nutrition, and Physical Activities Program. I'm sorry, demoted you from yesterday.
I got it from
and Dean Seidlinger, who is the Child Health Medical Officer for the County of San Diego Health and Human Services Agency, and he is one of your compatriots. He is an MD. Bonnie is not an MD. And Bonnie is the Senior Healthcare Manager of the Center for Chronic Disease and Injury Prevention in Santa Clara County Public Health. So we have three different public health, the folks in the local health departments that you'll be working with. And I will tell you, these are three of the most progressive and probably the most exciting counties that have done some really amazing work on this issue. So we wanted to see their perspective, and I wanted to also be able to have them share with you some of the realities of what it means to work with the different health, with champion providers and how they'll work with different champion providers. So I'm going to open up with a couple of questions. We're going to go through about half an hour of, I've got some questions I wanted to ask them and try and give you perspective, and then we'll open it up for some questions from all of you. So Steve, we'll let you start here. And all three of you, I'd like you to address the question, in what ways would a champion provider bring power or value to the work that you're doing in your local health department?
Thanks, Mike, and good morning, everyone.
Good morning.
So, just off the top of my head, I was able to brainstorm just now 3 ways.
Okay.
But I'll just hit on one and then let these guys talk. So first of all, I think yesterday one of the points that I think it bears bringing back is that you all have really amazing clout with the target audience. And based on a conversation at the end of the day yesterday, or a comment over here, and then some of the conversations that we had at dinner last night with some of my new friends from LA, I got the sense that you're feeling a little bit marginalized, maybe that you don't know exactly where to plug in. And you should know that you really do have clout with our target audience. When we talk to those folks that we're trying to help, they consistently indicate that physicians are the folks that they want to get health information from. In fact, the NEOP branch 2 years ago did some surveying of the target audience. They did 5 or 6 focus groups of African American, Latino, general audience, all low income, SNAP eligible moms who were very consistent with their comments in that they wanted to hear from physicians and dentists, particularly around the issue of sugar-sweetened beverages and sugary drinks. So I think you guys can go forward today knowing that you're the ones that the target audience respects, and you certainly, we certainly in public health deeply value what you can bring to the table.
Great, terrific.
Can you say what NEOP is?
I'm sorry, thank you. These acronyms we use, right? So NEOP is Nutrition Education Obesity Prevention.
And that is the branch that's actually developing this whole program, right? Dr. Seiler.
I'll echo what Steve said. I think the voice of physicians and dentists is extremely valued in the community. I think your patients listen to what you have to say. It may not always feel like it, but when you say something, they take that to heart and they try to make that change. One of the things I found when I was in practice at UCSD that was frustrating though is I had the advice that I could give the patients, and I would tell that, tell physicians or tell my patients about eating better, exercising more. They knew the message. It was then sending them out and not necessarily having them be able to carry out what we talked about. So I think that's where your local health department can really help partners. We've been working to try and change the environment so that when you give that message about fruits and vegetables in your clinic, about if you use My Plate from the federal government on talking about food, particularly to kids, that then parents can go out and have the access to the food that you're talking about in their community and not have it be an impossible situation. So we're here to support you as well. But I think your voice is respected not just by your patients, but in the community as well. Doctors are well respected. Community-based organizations, the thought leaders, the decision makers respect what physicians and dentists have to say, because they often do come in as not self-serving about what you need, but this is about what I see in my patients and my community. So I think that voice is very powerful and often can amplify messages that we as local health departments have, but make it even stronger.
Good. Bonnie, it's all you then. How can the champion providers bring value to the work you're doing?
Yeah, I echo, of course, the physicians hold a really unique and valuable place in the part of the education community. So that's great, and it's really important. And I don't think our physicians are out in the community sharing that voice as much because they're inside the clinics. And when our physicians do come out, and we are very fortunate to have some wonderful physicians in Santa Clara County that do come to community health events, come to leadership groups and share their voice, that they really are heard in a different way than public health professionals, epidemiologists, the nursing team, the dietitians. And so again, the voice and perspective and the stories that you tell are really powerful. I'm an administrator. I don't have the one-on-one stories. You guys work with clients day in, day out, and so the stories that you bring, that unique, I know with our pediatric healthy lifestyles, those unique stories that you can tell and only you can tell about what's motivating your client, what the issue is, those resonate. And we'll talk about that a little bit later also, but that power of the patient's story that just does not get out in the community is something that physicians really can bring forward in a very different way. Again, taking this, what you know, and taking it out to others is really powerful. The other thing you all know and have that can really, you bring uniquely, is you guys know the knowledge of the medical best practices. We in public health know a lot about evidence-based practices in terms of community norm change, in terms of environmental change strategies, in terms of education, but the medical and that link between the medical preventive strategies that you can then share in the community and share with your colleagues and groups is really important. And so more physicians speaking on the prevention, evidence-based practice will really be something really powerful and helpful to help move our communities forward.
Great, thank you.
Can I add one?
No, you can't say.
Okay.
You knew where that was going.
It's going to be a long half an hour if you keep going. So I just wanted to echo also what Bonnie said, because, in public health sometimes we tend to, sit at the top of our ivory tower that's filled with epidemiological data about population level impact. And sometimes that's can, it sort of can be, in isolation, it's not as impactful. On the other side of the same coin, a single story about a single patient it may not be impactful, but when you combine the two, I think those are the types of stories that I think the media will latch on to, and that I think can really help us move the conversation forward when you're talking about, here's the population, and by the way, here's a story about one of those people in the population that really illustrates the point. I think that's really powerful.
Yeah, absolutely. And I think it was well demonstrated on the radio panel we did yesterday when Christine brought in both the human story as well as the numerical issues and the actual numbers that help bring it all together. This is an easy conversation to have, a very theoretical, but I'm going to put these guys on the spot now to give us a picture of what they think this ideal relationship would be. What kind of thing might actually happen or has happened in the past when they've worked with physicians to try and do the type of nutrition work and physical activity work in the community to really make a shift on all of this. But also appreciating, and I'm going to put you guys in a box here, but appreciating we're dealing with very, very busy individuals who can only give so much time and also want to make sure that they're getting some real results and outcomes out of it. So, put you back there, Steve. How are you going to work with these folks?
Well, the way that I see this relationship happening, Mike and everyone, is that there's really two tracks, okay? There's track A that is where we're going to be calling with very short turnaround time. So, for instance, there's an assembly bill that's being voted on tomorrow. Some legislators are on the fence. We could use 10 minutes of your time to make a phone call to talk to one of the legislative aides and voice your opinion about which way the legislator should vote. That's a 24 to 48 hour turnaround time. The good news is that it's not a big time commitment on your part. So the smaller amount of lead time we give you, the less prep time you will need and it will take out of your day. And by the way, we would never put you in the position of being in front of the media or talking to a legislator without being prepared. So we have communication specialists that will sit with you on the phone or in person, review your talking points with you, review the issue, make sure you have the facts and the data. We're not going to throw you to the sharps and just say good luck. Here's the phone call, make the call. We're going to make sure you're prepared. So, take some pressure off of yourself in that regard. So, sorry, back to track. So track A is very short turnaround. Track B is more like a project where there's a timeline or some initiative that we know what's going to happen 30 and 45 and 60 days out. We know that there's a meeting in 30 days that it would be great if you could come and present. In that situation, you know it's coming. So I kind of see the two, either option potentially happening. And in the second one, we're going to help you with your presentation. If you need some help building slides, we have the data and we have the slides prepared already that we can likely lend. So, but that's kind of how I see it working.
Good, that's terrific. Dean, what's a scenario you'd see built out here?
So I'll build on the longer term aspect first. I think, in health departments, I'll pat ourselves on the back a little bit. We have a lot of great ideas and things we want to do and changes we'd like to see. But those don't always work if it's not, if the community doesn't buy in. And I use the term community broadly. So changing norms, whether it's in healthcare or in your patients, we may have some great ideas about what we think we want to do, but if there's not that champion that's in the community and on the ground, we're going to have a lot more struggles getting something done. So if you have an idea that you're passionate about, and you all have at least one idea, because Hillary made you, or Alicia made you write about it yesterday, that's something that we can help support you, and it'll further our goals, because, again, that person in the community with the passion, who sees the issue every day, and who knows what can be done to fix that, you're the best person to do that. So we can support you with things like data, who are other people who might be working in similar areas in other parts of the community or in other groups that you may not have thought of. We can connect you there. In San Diego, we've been very lucky that for childhood obesity, we've been working across these multiple sectors for a long time with people in the community that's coordinated by a community-based organization, but with public health and private organizations at the table. For the short turnaround time, I think, that's where we can really help get messages out. So if there's a message that we hear about that could build on something that's current, that's happening, some data that is being released, or an issue comes up, that we could reach out, and if any of you guys are available to help get that message out in the media, that'll help amplify that. They hear from local government a lot, and the media is a very critical partner in getting our message out, whether it's about immunizations, obesity, other issues that we want to get out, but they don't always want to hear from us, and they often want that personal story that we can't give them. But at the same time, you guys are out there and hearing different things through your professional organizations, through other avenues, issues that might come up, studies that might be released that are national or in another part of the country that you think, wow, this should get some attention here. We can help either bring some local numbers to that, if you want to get that story out, help you get to the media, or kind of help marry up our local numbers with a story you have and a national story that might be coming out in a journal or something that we may not pick up on as much, so we can support you in that short turnaround time as well. We're pretty good at responding to those kind of inquiries on a very short time frame. Some other things require a lot more lead time from us.
Very good. And Bonnie, I know you actually have done a lot of work with physicians. I'd love it if you could paint a scenario of how that's been put together and what you guys have done about it.
Sure. I just think I know you probably had this conversation yesterday, but to put to scale, we're a population in our county of 1.8 million with 340,000 SNAP eligibles. So it's a lot of people, a lot of volume. So again, a lot of these strategies are one-on-one with individuals versus population, environmental strategies that really do start to change sector by sector, and we speak in code. The school sector, the healthcare sector, the city's jurisdictional sectors, the faith community. So kind of whatever you're up for, think about what you want to do, and we've got room for the physician providers in any of these sectors to do a range of work. Because our responsibility, and our physicians in our community have been very helpful in this also, it's for all the way from individual education up to working with the county and cities on policy level change. And there's just layers. And so I think you had 2 points, I think I have 5, too many. Too many things we can think of you can help with, but there's lots of room and lots of opportunity, and public health, I think has been said, we spend a lot of time strategic plan. We got a lot of plans, and we got to implement them. And so your help with picking the priorities on implementation or bringing that voice is important. So I know, I'm going to focus to answer that quick question, like what are the key things? And it really depends on what you want to do. What are your passions? What are your strengths? Not everybody's a storyteller. Not everybody wants to go to city council meetings on a Tuesday night. Not everybody wants to come to the community events. But if you are a person who really wants to go out and be involved in the policy level work, it's using your voice and going to city council meetings and talking about the population you serve, the health inequities, the health disparities, and then what you think a city could do to really support it. Have policies that support healthy food and beverage. Put active transportation and work on transportation policies. Work on any number of things at the city level. If your interest is healthcare in your system, my goodness, our healthcare systems have a lot of work to do to be promoting health. And so again, you could work with changing your systems, having healthy beverages, safe and active transportation policies in your system. So you can do a systems approach. You can open doors for public health to come in and help bring you the resources, materials, education that we have to really make those changes. So the final one is community events. We love the physicians to come out to community events. You guys are fabulous voices. If we have, we call them our signature events in a community. I know Dr. Mendoza-Levy is a fabulous leader for us when we have the Gilroy Health Day, when we have the Binational Health Week Conference. Again, being part of some of these ongoing community events and engaging and setting the platform for it, as well as showing up and using your voice there is really powerful. So I'll stop with that.
No, that's terrific. And I think one of the things hopefully that you're hearing here is there's an enormous level of flexibility. And it's why I really love this panel, but we have all 58 counties are funded through the health department to do this type of nutrition work and to work with you. So universally, hopefully you're going to see this same type of openness to a partnership that'll bring this forward. But I wanted to take this now because I think it's important that all of you understand, just as you have limitations, all of these folks have limitations too. And I'll grab questions in just a second. But I wanted to ask you guys a final question, and we'll go and take the questions from the crowd. What would you want the docs, these providers that may be working with you, what would you want them to know about some of the restrictions, the limitations, the realities of your work, so that this is really an honest partnership, and they're not expecting that you're suddenly going to drop everything and be able to give them everything they need, but there are some restrictions. So, Steve, I know you're loaded with restrictions.
Well, one of the key ones one of the key restrictions that we have is, and I think this applies to all of us, as civil servants in a public health department, we can only publicly speak and take a position on issues that our board of supervisors has taken a position on. Regardless of the evidence or what the data suggests, even if their position is contrary to what we believe the data suggests, we cannot talk about it. Or we cannot take an opposing position or take any position if the board hasn't taken a position. So I think that's one of the really wonderful advantages of working with all of you, is that you can say stuff that we can't. And so I think we'd love to be able to leverage that, because I think we're like-minded in what we want to have happen. It's just that we can't talk about it like you guys can. Do you agree?
Yeah, I think it's part of our job, I think, at least on my level as a physician in the county. If there is something where the board has a position that's contrary to what the evidence is now showing, part of my job is to educate behind the scenes. But in public, I have to speak on what our board has voted on as policy. And in this arena, it's fairly easy. In the nutrition physical activity, we run up to a few roadblocks when we talk about things like sugar-sweetened beverage taxes, which may seem like a great idea, but our board has certain opinions about taxes in general. And so, as someone who works for the board of supervisors, I have that opinion in public as well. So, we do have that kind of constraint, and whereas you guys have a lot more flexibility in terms of taking some of the evidence from a professional organization, from the latest research articles that come out, that you don't necessarily need a higher power to tell you whether or not you can talk about that.
Bonnie?
Yeah, and
Oh, she's looking at her notes. I
I know, I got
see
no
18
post-its.
points.
Oh, I was talking to our LHD manager, Lori Martin, and this is the one you always go, oh, those restrictions, which do get in the way, and which is why a lot of our public health departments are looking always for outside funding to give us more flexibility and more bandwidth in terms of getting this great work done. But the restrictions are USDA, and you probably had them in 101 class yesterday. I'm sorry.
We didn't do that.
And okay, I was working on a grant, so I'm sorry I couldn't join you yesterday. But we have restrictions, and that NEAP has the USDA is our funding stream, and so there our target audience is the SNAP eligible population, the population 185% of poverty or below. And so we have that as our, kind of the target population. So we can serve the population quite well, as long as we're working in a location that qualifies. So we have qualifying sites, we have qualifying education materials, we have qualified messages. So, and we don't do medical nutrition therapy. Those would be the fourth quick. We're wonderful in a lot of things, general nutrition education, but we don't do medical nutrition therapy, and we are happy to work with everyone in the community as long as it's a qualifying site. So there's just the restrictions based on the funding stream that maybe don't make us as capable and able to do everything that you might ask for us. And again, going back to that 340,000 people, and we have a staff of 7, it's a capacity issue, just like your workflow, our workflow. It can be a capacity issue in terms of what are our core priorities, what are our strategies we've agreed to work on already, where are we putting our time and effort, and can we tease a little bit more out for something that we don't have in our plan that we're moving forward on.
Good, thank you very much.
Can I just build on that a little bit?
Please.
And I think, so one of the phrases we have in public health is if you've seen one health department, you've seen one health department. So each of the 3 of our organizations are very different, as will the organizations you talk to. Which resources kind of have come together and are kind of under the health department and kind of can be leveraged, and which ones can't. So we've been focusing really on our USDA funding that comes through for nutrition education, nutrition, physical activity education, as well as some of the upstream policy changes. But then different groups will have that kind of leveraged or married to different funding sources or different priorities that could maybe bring in to help further a project that you guys are interested in.
Terrific. So I'd love to open this up then for some questions. I know we had some questions out here so that you can ask the panelists some different pieces. You were first up with your hands, so I'll let you start.
Well, I just wanted to ask Bonnie if she would talk a little bit about something that is going on in Santa Clara County that I was kind of excited about, and it's a pilot program right now that they're doing in Milpitas with a public health educator actually physically in the clinic. And just wanted to have you talk a little bit about that to the group.
Sure. We're always trying to find new ways to get good work done. Thank you for bringing that up. Public health is trying to see what role we can play and really help with between the clinic and the community, that gray space where people come into the clinic and they go out and live in the community, and how can we help find that services, resources, linkages within those two worlds, as it were. And so in a couple of our health centers, we have modeled and tried and have the support of the medical director to really do something differently. And Milpitas is one of our clinics where we have a health educator who is working in the clinic working for public health, but kind of has a shared space. And again, is looking at leveraging the resources and support and messaging that we're doing across the public health programs, such as Rethink Your Drink, safe and active transportation, tobacco prevention, and then working within that clinic to have tabling and events, to have some classes, and then also link and go out in the community and look at what are the local resources where somebody could, do physical activity or put a farmer's market on with the library right across the street. Again, what are the environmental changes that can be made that we can then help refer the clinics over to the community to help the clients have a better chance of making healthy behaviors outside the four walls. That's a little, kind of in a nutshell, but about a project that we're really trying to, it's a great area to work in with all healthcare reform, and really as providers are working upstream in prevention, how do we really help break that barrier between the two where clients really can make those choices.
Great.
I'm anxious to hear from the health department, another health department.
Just a general comment. For California is different from other states. So you mentioned we have 58 counties, 61 health jurisdictions. So you have 61 physician health officers in California. So every county has a physician health officer, and you have a public health department. Sometimes, usually there's two sort of key roles. There's a public health director and the physician health officer. Sometimes they're the same role. So it's really important to recognize that, because I think the physician health officer, like I would disagree a little bit. So for example, as a physician, I have an ethical responsibility to speak out on the science of sugary beverages and the health impacts it has. Okay, even though politically, politically here, our mayor has not taken a position. I cannot do it in a way that I don't talk about soda tax, but I can talk about the science and I can talk about the health impacts. And I can work with the clinical community around those issues. And I do steer away, I agree, I do steer away from a specific policy. But I think take advantage of your physician health officers, because they can use their public health ethics and their ethical responsibility to speak out on health issues that's based on evidence. And so I think it's important to realize that.
Great.
And again, the physicians, that's what I was trying to get to. There's definitely things that we talk about in that evidence. Our job is, if the evidence has changed and is contrary to what our board says, is behind the scenes to provide that education. We're not going to necessarily take that public position on soda taxes until they come out and say it, but we're going to do, you can bet that we're behind the scenes providing all that, and we will reach out with what is the appropriate medical or health, the accepted policies or evidence behind the programs.
Great. I know there's questions, but can I just elaborate on that a little bit? So just another example. Just recently, there was some legislation called SB 1000. Did you all hear about SB 1000? That would have put warning labels on soda cans and places where soda was served and sold. That basically said, warning, this soda, or this beverage contributes to obesity, diabetes, or just something along those lines. And
Makes
so-
tobacco warnings, but that's what it came to.
very similar to the tobacco one. And it looked like it was going to pass. It was green all the way, literally until the day before. And we received an email from some advocates that wanted our support. And the request was basically, can you have a physician call these legislators and voice their support for this bill? And so because our board hadn't taken a position, although I recommend they did, but they did not. It's their prerogative whether they do or not. So they hadn't, and so we couldn't have the physicians that lead our department make those calls. We were able to reach out to some folks that we work with regularly at the university level that are public health oriented folks, but the legislators have heard from them for years, and so it would have been a perfect opportunity if I could have called one of my colleagues from LA to say, can you call, just make a 5-minute call, here's the background, I'll spend half an hour with you going through it, and just make a quick call on your lunch break or whatever. It really would have been a great opportunity. So that's the kind of thing I think, when I was trying to illustrate, it just illustrates the point that we're a little bit handcuffed sometimes.
Good.
My comment actually dovetails on that. Your first mentioned about different kinds of commitment, short-term and more timeline commitment. And one of the first thoughts I had was, well, I don't know enough about that to speak on it or to advocate. And so I think that one of the barriers to even probably more to a short-term commitment where you're talking about a 24-hour or 12-hour, turnaround, is needing to really be spoon-fed what are going to be credible, reliable resources in a quick, digestible way. Because I don't think I can offer my time unless it's 99% prepared for me to do so. And you did actually make that point now when you were addressing it. My first thought when you mentioned this was, yeah, but you said it's a short-term commitment. Well, not on my part if I have to go and find all the research to back up the statement I'm going to make. So I think the only way that I'm going to feel more willing to step in is knowing that there's something that's been prepared with that phone call before it's made. Look, I'm going to send you everything, look it over, give me I'll call you back in 20 minutes. Is that enough of what you think you'll need for tomorrow to do this? And with that, then I would be much more willing to say, got it, yeah, I can do this. I really love the points and I can make those.
Good. Bonnie, do you want to comment on that?
Yeah, I think it's a great point. And again, in public health, we're used to feeding leadership with information and taking a ton of information, put it into a few talking points. What don't you need, what do you need to understand? We do that with our director all the time. We do that with our health officer all the time. And we also sometimes do it in board briefs when we're trying to get the board to look at taking a position on something. So you're asking for something that should be very reasonable for most public health departments. And most staff that are working in chronic disease prevention are doing that quite frequently. You're just pulling all the data. And then we also know all the advocacy organizations who can help us out if we don't know something or you want to say it a different way. And then we could also help introduce you, if you don't know your health officer, they've probably been prepped on it too, or if you have a board member that's an MD, they might have been prepped on it. So you can help find some of those other people. Because again, to say it in a way that you're comfortable with is always going to be important, but there's a lot of resource out there. If it's a platform area, we're working on.
And I think the short-term commitment from you for information that you would have to gather yourself is really just to find that personal story. What have you seen in the office this last week, this last month, which is something that would probably be fairly easy. But in terms of numbers, position statements, evidence, the articles, that's something that if we ever asked, at least I can speak for us, and I think all three of us could say, if we ever reached out to say, could you answer this media inquiry, or got this inquiry from a legislator, here's the information you need, and if you needed more information, we would give you even more.
Can I add something to that, having done this for many years? I want to reiterate that this is exactly why we did the media training for you, and this happens to me all the time, and I just say, that's not my area of expertise. What I can tell you about is the patients I see. And sometimes I do know something about the issue, and I say that, but the messages from the LHD, honestly, they've heard before 100 times, and it's much more refreshing for them to hear your perspective on it anyway, so I wouldn't let that dissuade you from trying to follow through with some of these things.
And let me one added, because I also want to make it very clear that you're not going to have your local health department dictating to you, this is our policy, support it. It's going to be this partnership. There may be policies that they're very strongly working on in platforms that are not your passion or is not a place that you really want to plug in. You are not a slave to their needs. They're going to give you opportunities. If they sync with your sensibilities and your appreciation of that approach, then by all means. But it's definitely not, we need you for this unless you really believe in the direction we're going. Because frankly, having a strong support and having a real passion behind it is every bit as important as having the background and the knowledge of the issue as well. Christine?
Yeah, having done, I call it SB 1000, we have sort of a network in San Diego where the director of our Child Abuse Initiative, she has many of the physicians' emails. So she emailed several of us and said, could you call? And she gave us the phone number to call, the bullet points in an email, very, very easy. And, you know, I tell people you don't have to be the expert. I mean, sometimes we feel like, oh my gosh, I have to have all this data. Well, first of all, I'm going to tell you, when it comes to calling your legislative office, they're not going to give you that much time. They want to know your credentials, what your position is, and just maybe you'll get a few minutes to say something about why you believe this is true. So it does not have to be, you're not going to be giving a 20-minute talk. And one other thing I just want to mention on media, again, this comes through our AAP chapter. They have now partnered with a media relations, public relations company, and basically they look for opportunities for us. It's on many things, pediatrics, but some of it does come across as nutrition. And they basically, she sends out an email to, again, some physicians who are comfortable with media, and we go out and we say, can we not do it? But it's amazing how many times within a last minute thing, somebody can do it. And in addition, they give you all the bullet points. I mean, I did it once for them. I mean, the media guy meets you down there, makes sure you're comfortable. You know, so it can be much more programmed, basically, which is nice when we're able to partner that way.
Hi, I'm from Riverside County, and I'm a physician in one of the county clinics. And I know that there's people in the audience that have administrative power, but I'm a physician, and I don't know how many of you guys are physicians. So I think, like, what I'm seeing myself doing when I go back, I know we hopefully in the long term, we're gonna hopefully change some policies. And I know the community that I work at, they don't have enough sidewalks to walk, they don't have enough parks. So all of those things, I think that I see maybe myself having an input on long term. But in the short term, I think that in my community, I know that there are groups already of people working in the community. We have health coaches coming to the clinic recently, thanks to a partnership that we did with a local university, UCR. So they are trained in nutrition, so they are coming every day, they are giving educational nutrition to patients, and we're happy because we can provide them with materials that we can get from maybe Champions for Change, and they can use it. We also have promotoras of salud, or health promoters, that we don't have them in the clinic per se, but I know they're in the community. So my goal will be, when I go back home, try to contact everybody in the community who can help us. But we just have to open the doors in the clinic and let them come to the clinic and help us maybe organize it by little the community, hopefully the schools. I think maybe if we do that and then we get as many champions in the community as we can, later on hopefully we can maybe change the policies and we can just give them the education that they need.
That's a great point. I'd like to actually ask the panelists, coming from that, we've talked a lot about some different policy, but there's also working with community groups and community organizations. How do you see your role working with the champion providers in syncing up some of those coalitions or those different opportunities where and will the champion providers have strength? Will they bring real impact to those opportunities?
Well, I'll use our South County as an example. We have, again, a large county, and we have 15 cities, and we have one area in South County, and we have right now we have a leadership team that's working on how do we change South County for health. And so we have, again, a school sector, a clinic sector, the government sector, our city electeds, and then a healthy, safe parks. I think that there's as you're saying, go back and see what other group is already working in that neighborhood. And there's a lot of work going on to look at play space. So again, focusing in around the clinic, what are the obvious areas that you can start to work on for healthy and safe parks? Maybe you're already working, or maybe there's already a group that's a gang prevention task force that already is working on making the parks more accessible and less violence and more easy to have physical activity. Maybe there's an interfaith group that's already working on, again, one of these areas that you were talking about, the long-term changes. So when you reach out, know that there may well be some groups already doing it, and your guys can added value rather than taking the time and energy to have to try to coordinate it all. I think would be really important, because I know you're busy and don't have a lot of time. So we're still figuring out who are all the other groups that are doing all this great work. How can we link and really leverage that so each person does a small amount to have the big impact? And so I think that'll be important within your system too. If you already have practice changes in your clinic, that you already have a healthy beverage policy, if you already have some good PA policies in place or breastfeeding promotion, then you show as a leader that already has made these changes, and then your voice is even more powerful when you go out in the community and ask those organizations, oh, we did it. You too can make, a 100% healthy beverage policy in your organization. This is really easy. Here's all you need to do. We can help you. As you were saying, here's the education materials, the resources, the posters to kind of change the environment so it looks healthier, and then make those practice changes. So, yeah, pace yourself in terms of how much you can take on at one time on it.
My question is for the panelists, what outcome measures do you currently use at the county level to measure the wellness of, say, your children? And should part of this process be at the end of the day of this pilot, us formatting some standardized measures that we'd like to sort of include for different county health departments for use, such as a pipe feeding, a community BMI, or access to fresh fruits and vegetables, or transportation policies, getting into the nuts and bolts? Should that be part of this process where we develop like-minded outcome measures that we all work on in our individual counties?
So we'll start with the focus on health outcomes first, instead of program outcomes. I think, you may come to us and say, oh, can you give us how many kids in this neighborhood have this disease? So let me tell you a little bit about some of the limitations that generally happen for disease. We have really great indicators on how many people die of a certain disease, how many people are hospitalized, and how many people go to the emergency room. That data is well collected. It lags a little bit, but counties can provide that. Then we have some great self-report data through the California Health Interview Survey that can be broken down to the county level, and in some counties to smaller areas and even to community areas on self-reported health. Body mass index is in there as a self-reported variable. Experience with certain diseases, asthma, hypertension, other things are in there. What we're missing is some of that middle part, where if you ask us, how many people have hypertension in a community, we may not be able to do that, at least across the state. In certain places we can do that more, and I think across different health departments, we're looking for more innovative ways to get to that more granular data. Because what helps us do our job, what helps you guys do your job when you go back, what helps our communities is if they can say, here's what health looks like in my community. Here's the prevalence of disease in my community. So, you guys have a wealth of that information in your EHRs. And so, partnering those kind of partnerships between health departments and healthcare providers to kind of try and pull some of that out together in a way that can be presented to the community makes sense. We've been working in San Diego for many years now on BMI surveillance. So we started with a self-report module where providers who are using the immunization registry could put in height and weight and get computer-generated growth charts. This was before EHRs really came into being. This required a lot of dual entry. So after a few years of that project, we had 4,000 records. By linking up to individuals' EHRs, compiling that information together, and now we have over 2 million records in there on BMI. And so getting that into a format where we can feed it back to you and say, okay, Stu, you practice in this community, here's what the obesity rates are like for children in your community, here's how they compare to the county. We can try and do that, but certainly those are conversations that health departments and health systems are starting to have more of, so that we can provide that more granular data that you need, because self-report of illness to death, there's a lot in between there that we just don't have a great handle on down at the community level.
And public health is rich in data and outcomes, and so we look at short-term outputs, medium-term outputs and outcomes, and so, changing the obesity is going to be a long-term outcome. We're going to see that slowly. We have these great tracking systems, behavior risk factor surveillance, the youth risk factor in terms of the population data, and then we also have, let me stop on that. In our county, we've looked at and we've heard from people, it doesn't do me any good to know that, the overall population's data, tell me at a more granular level. So our EPI team has spent a lot of time doing the population-wide data and then break it into city, and now they're getting down to neighborhoods, and there's a lot of reports up on the website that I don't think people even know about that starts to give you that level of data. Well, we're spending a lot of time now directing the community to the website because a lot of it's there, which is wonderful. And then we do a lot of, as I said, a lot of assessing and reports and looking at, what is our outcome we're looking for based on programming. Like I said, we're going to increase bicycle miles or bicycle path miles, or we're going to work on increasing the number of organizations to 350 that have healthy, food and beverage policy. So we have a lot of different the outcomes we're looking for, and then we do outputs more on a programmatic level that we can then track and measure on many different things. So we're just, again, working with your departments or your community and figuring out what do they have and what do you want to work on together.
Great. Go ahead.
Somebody asked what NIAB is at the beginning, and I just want to say that NIAB is considered one of the largest, if not the largest and longest running social marketing and obesity prevention program in the country that works with low-income communities. So besides the commitment to address obesity prevention, nutrition, and physical activity with your patients in the clinic, I was also going to recommend, and I think we've heard this before, to venture out of the office and really get to know your underserved communities that NIAB works with. We've worked with African Americans, Latinos that suffer from the greatest health disparities. In San Diego, for instance, we have a mom. Her name is Latanya. She's a single mom of 4. She went to community college to get a degree in cosmetology. She can't afford daycare, so she works part-time. She gets paid $1,000 a month to pay for rent, to pay for food, and for transportation. So this is the community that we serve, and that would be my recommendation for you to get to know our community. We've been able to recruit champion moms, champion pastors, champion decision makers that are very engaged in their communities. So get to know the initiatives that are going on with your local health departments. There's many exciting initiatives going on right now. We are working with liquor stores and connecting them with our local farmers to make sure that they offer fruits and vegetables. We have restaurant initiatives that offer healthy menu to kids. We establish farmers markets in low-income communities. We open community gardens in schools. There's lots of things going on, and I think that Champion provides an opportunity to link the patient with community resources. So NIAB has many resources besides what has already been shared here. We have marketing materials that you may be able to utilize at your clinics to promote healthy eating, physical activity, drinking water, etc. We have posters, we have cookbooks, and we're also very well connected with the community-based organizations, federally funded programs. So if you have patients that are suffering from hunger, or if patients that need information on healthy eating, we have those resources for you.
Since we talked about resources, just so Blanca represents another resource that we have. She's at UCSD, but there are regional technical assistance providers that are funded to help the counties and the partners we work with on some of these issues. So, the same way that we're here to provide resources and some help for you, we also have regional folks who are there to help give us resources and provide us some guidance. So there's a lot of support out there.
I want to thank you for putting on this conference. It's really making me think a lot more how to work outside the clinic and thinking a lot about the environmental impact. And one of the things I feel a lot as we look at how many people are eating out, and also as a parent of young children, one of the frustrations when we go out is the children's menus are horrible. I found the occasional exception to that and really rejoiced in it. Fortunately, I don't think that really locally to me, but sometimes when we travel, there's a place in San Diego that was wonderful. But, I think, I'm just wondering if there's any work done either locally. I'm wondering about working with local restaurants, Chamber of Commerce. Has any of that work been done to really try to address that issue of providing healthier options for people who are eating out?
Great question.
So this is one of the really great benefits of the LHD model, the way that we're able to leverage different funding streams. So in Los Angeles, we've got a fairly robust First Five funded project that's working with restaurants to improve their children's meals. And then through our community transformation grant at the Public Health Department, we started a volunteer restaurant recognition program where, and we've got 700 or so restaurants, including most of the subways, that just had to make a minor tweak in order to get on the program. In exchange for public recognition, they offer free water to every customer, they offer reduced size portions, they offer whole grains and lean meats. So yeah, that's some of the work that we've done.
And I think, the approach from the local health department perspective, and I think the approach if kind of restaurant meals is a passion for you, the approach with businesses is always tricky because these are private businesses who need to survive and need to make a profit. And so how can we make these changes, work with them to support these healthy choices in a way that's sustainable? Because if we come in and kind of mandate and do things and people aren't buying things, it's not going to sustain. And so I think there are different concerted efforts. One effort locally in San Diego was looking at Asian restaurants. So they worked in Chinese, Thai, Filipino, and one other type of restaurant, I can't remember, to work on incorporating changes in recipe preparation that could make those options healthier. And these are, across the state, these are mostly family-run, small, independent restaurants. So you can't go to a chain or a corporate office and make a change across multiple. It's individual location by location. And our federated qualified health centers actually had staff that worked with them on recipe substitution and other things. So it's certainly an area that different people are working on the recognition side, working with the providers. And when you find a place like that, certainly bring that to the attention of your patients, or bring it to the attention of the local health department. And we want to promote those businesses that are making those choices so that they are sustainable and they succeed.
Can I just add also, you and I are actually modeling what we hope to achieve right now, because we have work in restaurants that's starting. You have a passion for restaurants, you're a physician, I'm a public health person. Let's get together in front of some television cameras and tell people about this work. And I think people will listen to when you say, I have a concern about the children's menus in restaurants, that speaks volumes.
Yeah.
Can I add to that too? The other interesting thing is that I live in South Pasadena. It's a small city. Our mayor is a physician who's concerned about these issues. So, we'll talk further, but there might be some interesting things we could do to get something at least started.
Well, I'd just like to add that this is an important piece of the conversation too, because we started with a lot of state legislation and policy with a big P, but this is the type of work that, especially at the county level, working with your local health department, this type of system changes in your community, block by block, individual by individual, is where we build that wellspring that's going to support this. So don't let this become this idea that it's the big P. We're going to see just as much power when we're dealing with policy change that's in a business or smaller entities. Those are where we get some real sustainability.
Hi. So I guess my question is specific for Steve since I'm in Los Angeles, but I understood from what you said earlier that the way that we can kind of provide assistance is from advocacy level. So if you need a phone call, if you need us to take a phone call, if you need us to show up at a meeting. But in addition to that, are there pet projects that you have? Are there 2 or 3 of your wish list that you'd like to accomplish in the next year? Specific for Steve, but then if anyone else in the panel wants to address it for your constituency, that's great. Secondly, and I'm assuming this is what's going to happen at the end of this meeting, that we'll have a way of staying connected so that, we're part of the loop when you're sending out information about this. I'm right next door to my health department, and there's so much going on in the health department next door, and I honestly don't know about it. Partly my fault, but it would help a lot if we were on an email list so that we could get this information on a regular basis. So pet projects that maybe we might want to join, and then other ways that we can kind of stay connected in the future for this. And one more thing, it's got to be a policy change for restaurants. Restaurants, are not going to want to just voluntarily change the kids' menu if they know that mac and cheese and chicken nuggets sells to kids. They're not going to do it unless it's a policy. Parents don't use seatbelts routinely until it became a fine if they didn't do it. So I think that's
but that children's menu is not going to survive if people aren't buying it. So parents will start moving to an adult menu,
Menu.
getting those,
That's true.
so we have to balance that. Yes, we have to have some direction in that, but it also, as a business, for them to succeed, it has to sell, and that's where we can all work together, so. Now it's super.
So I'll answer the second part first. So, absolutely after this meeting, we will, I think this is sort of the opening salvo of kind of getting us connected. And I think my NEOP project director was able to connect with all of you before you came. So that was actually the first attempt, and we will absolutely be in contact after this. And I hope to develop personal relationships with all of you. I think we got started last night over dinner. So absolutely yes. In terms of pet projects, the restaurant issue is certainly one. What's nice about that is that, again, it's leveraging different funding streams. With NEOP, it's not part of our NEOP project, but again, it's a benefit of the local health department model to be able to leverage other funding sources and plug you into other areas. I have a passion for childhood obesity. My background is from schools. I'm a registered dietitian by trade. I spent 10 years in food service director and working in nutrition education in schools and improving school menus. I think that's something that I would like to see long term, although I'm here to tell you all that school meals are better now than they ever have been. I think I mentioned that last night. But can they improve more? Yeah. We are well connected in terms of working with LA County Office of Education and LAUSD, two big providers of school meals in the county. So that's one that I would like to see move forward, and I look forward to working with all of you on all of this.
Go ahead, Bonnie, and then we'll take one last question.
There is method to the madness, and we do all have plans on what we're working on this year in terms of pet projects. We've spent a lot of time engaging a lot of the community. Each of the counties has something called a CNAP, a County Nutrition Action Plan, which highlights what all the providers who are receiving SNAP Ed funding are working on together, the key initiatives, what they want to move forward on, both in education and also in this new arena for people, PSE. And so in our county, it's retail environment and organizational practice change are the two that we're going to try to take from education through policy, where there's lots of great resources out there and proven practices on policy, so you don't have to reinvent the wheel. We go to toolkits and find resources. So we all have community nutrition action plans, which you can then meet briefly with your, rep in the LHD, and then they can try not to bore you and tell you like 17,000 things, but just say, give me a high level view of what we're working on, where I can plug in either geographically or project wise. And then the other thing, we're all attached to regions. There's these regional grants that are also out there, and we all have regional collaboratives, and each of those regional collaboratives, ours is Bay Area Nutrition and Physical Activity Collaborative, also have key initiatives. So ours is Rethink Your Drink, and really now building out a model on physical activity. So there's things you can easily hook into. Our pet project, I can tell you what my pet project is, but we already have plans on what our community is moving forward on together, and so that might be a way to really enhance and jump in.
We're going to take a final question and then wrap up.
So I have 2 points. One is maybe if one of you guys could comment on Measure of America. Do you guys know what that is? So I recently saw a presentation at my clinic. It's all of the granular data that some people have been talking about, where they did county by county measures of literacy, high school graduation rates, all kinds of health sort of health outcomes by ethnic background. And you can, so measureofamerica.org is the website, but then you can go county by county. So I saw a fantastic presentation on Sonoma County that was totally eye-opening, and I think would be really interesting for people who are interested in kind of getting involved in their county, just to kind of get that background. And then my second is more of a question, which is that I don't really know who I'm representing when I approach the public health department. Am I just me as the doctor, or am I part of the clinic? Do I need to have the buy-in of my clinic, or this is one of those ways doctors are always accused of being, lone wolves, and so that's a question maybe more for people that have engaged with their public health department, or more for people who have leadership roles in their clinic. Do you want approval from the people working in your clinic before they approach the public health department?
It's a great question, actually, and you all may have some input, but I would suggest to you that first and foremost, you are representing yourself. You should obviously work with your clinic, let them know what you're doing. If they endorse this, it gives you more freedom, that's terrific, and probably more clout and power. But the model for this is, first and foremost, individual providers, but bringing groups into this, I think, gives you more flexibility, more power, and hopefully some more time and resources as well. But it is a conversation all of you will need to have with your bosses to decide what level, whether you're doing this as an individual or whether you can bring your organization into this as well. And we would love it if you did bring your organization. Numbers mean more power.
Yeah, I think your voice as an individual position is really critical and key. But you know, the organization you work for may have certain, maybe more supportive in some areas, less supportive in others. So certainly engaging leadership in the organization you work for, but then thinking about your professional societies as well. And so, if you're a pediatrician, can you be the voice of 5,600 pediatricians across the state of California or part of the AAP? As a family physician, could you be, you know, if there's a policy on that, could you be the voice of family physicians across, you know, that, yes, you're speaking as an individual, but if you then say your clinic organization behind you or a professional organization that's taking a policy and supports that, that magnifies what you say even more.
So I'm going to close, we need to close this out. But they'll be here. They've been, Dean and Steve were here all yesterday, Bonnie was working on that, but they'll be here if you want to talk with them. I think the important thing that I'd like to point out, I love working with all three of these. I've had years of opportunity to work with them, but their counterparts are all over the state, and they are just as excited to work with you. They have that entire toolbox of resources that they want to put in front of you, and they see you as an incredible partner. So do not lose the opportunity. That's where sustainability is going to come from, and that's where your support system will come from. So please make sure that you are plugging into your local health department. And if you have any problem making that connection, get back in touch with the organizers of this, Susan and the rest of the players that have been involved, because we really want to make sure this works for you. And thank you very much. It's an incredible panel. Appreciate it.
Thank you. So.